Um, work. Mandar el cuchillo, ¿no? No, no. Yo voy a dormir.
Vamos a montar una pastelería en Colombia.
¿Cuándo vas a ir?
Pastelería La Nébula, vamos a poner.
Ah, bueno. Hacemos solamente pasteles. Con
pasteles
cerebros.
En forma de neuronas, cerebros sangrantes.
Ah, qué chévere.
Una pastelería temática. ¿Qué te crees, algo?
Tomás, qué bueno. Está excelente la idea.
Bueno. Expresivo, Me quedo muerto.
Hello, Saeed.
Besito, besito.
Tanta creatividad.
Hello, Saeed. Oh, Takashi, too. Good day, Takashi.
Hi, John.
Hey, Saeed, how you doing?
Fine, and you?
Hey, listen, Saeed.
Yes.
I haven't heard from Dr. Sabaya, but I know he's going to speak at the conference. I offer him a spot in the conference. He's going to speak at it, but I haven't heard from him as far as knowing that he's not speaking that day because I've got a conference to televise. Okay.
Okay.
Can we do it on Friday at the same time?
On Friday, this Friday?
No, not tomorrow. The next Friday.
No. Yes. I mean next.
Yeah. With a French speaker, if possible. Okay. Can you? I'll try to get one too. Okay.
Okay. Yes.
Yeah. Because it'd be nice to keep in French. And that's another reason, really. I'd rather have Dr. Sabaya speak somewhere else. But I tell you, Si, things are going great. They're really going good.
Yeah.
And we're getting a little more viewers, more communities. They're getting more deeply entrenched.
Yes.
So
okay.
We just got some good Chinese webcasts coming. Yeah, I should be asking you to present because we need presenters in Latin America. We take English. English is fine. But do you want to do some webcasting? Presenting also besides the French?
I have a fellow in my department. She's interested to participate.
Oh, great.
Yeah,
Have her. She can moderate. Does she want to moderate? She can if she wants.
She was fellow of Professor Raftopoulos in Belgium.
Oh, good. No,
Yes.
she can do what I do. She can say, hi, I'm from Reunion. I'm from Neurosurgical TV. I'm working with them. I'd like to introduce your associate. I forget his name, begins with T. That's all I remember.
Yeah. Okay. Takashi.
Yeah. Oh,
hey, there's
good
Takashi.
Evening. Hi, good evening.
Nice to see you.
Yeah, nice to see you. Nice to see you. Yeah.
It's a good time for you, right?
It's at midnight. It's midnight. I just take a bath and before going to bed, but I attend to learn.
Good.
Yeah, that's
good. Yeah, there's the hour changed again. There's another hour
Yeah.
You got to be careful, man. In Latin America is the same thing.
Yeah.
It'll change all of a sudden, and you go, no, it's 2 hours difference. You know, that's not your job. That's my job. But
Okay.
things are going really well. I was telling Saeed, things are really going well.
Yeah.
You know, I really don't want to try to tackle Japan until we really get strong, Takashi, you know?
Yeah. Okay. Yeah. Japan.
Because it's tough. Japan, I know, is going to be tough. Very tough. We'll do that later. In the meanwhile, I don't know. I could go to India for a while, for a month. I don't know. I might do something.
Yeah, I try to go to India. I'm thinking of going to India next January.
Oh, for Ike, to see Ike?
Yeah, what done the meeting? It
Yeah.
will be held in January in Jaipur, so I want to
okay.
attend.
Oh, okay.
Oh, it's
Okay.
interesting.
Yeah, that's I don't know where that's at. He's had one in Spain. He's had one. Yeah, you have every couple of months. One in. See, we did one in Spain, and Beirut, not Beirut, in Lebanon, I think. Did one a couple of months ago. Yeah, there's a Zoom conference now on the technology of Zoom. You know, what they have planned in the future. And I wanted to really watch. I didn't have a chance really to watch too much of it, but they're adding some nice things, timers. They're building it out now. They're building it out, and I was really watching for how they're going to incorporate AI into AI and augmented reality, because I know they got something planned to be able to do augmented reality through Zoom.
Sharath, he's here.
Hello, Sarath.
Hi. Hi, John.
How you doing?
Hi, Said.
Hi, how are you?
I'm fine. I'm fine. I'm good. Thank you. How are the things, John?
Good.
Always busy, no?
Yeah, people join as we go along. But your associate is coming.
Yeah.
So how are things over there?
Not too bad.
Good.
So
COVID's over, right? More or less.
Yeah.
Yeah. Yeah. Apparently, they're still strict in China. They're still really strict. They have quarantine when you change cities, even like big cities. You gotta go in quarantine for a week.
Oh.
They're strict. Other countries are relaxing it now. I guess I don't know if it's still going on there or what.
I think Ayush may be getting a little bit late, maybe around 5-10 minutes, so we can start on time and continue. Yeah.
Yeah, there's no hurry.
Yes.
He's the main speaker, right?
Yes.
Yeah, no problem. But you did hear from him, right?
Yes.
Okay.
So what I do, John, as usual, I will start and I will give the introduction and, a little bit of presentation on theory, and then we'll go for case discussion once it's there.
Okay.
I think he's there.
Yeah, there's no time limit. We have lots of time.
Yes. Yeah.
Yeah, hello.
Good day.
Good day to you. I cannot see my video, but I think
It's the Laser King of India.
nothing
The
like that.
Laser Spine King of India.
Yeah. So I cannot see my video. Like, do you?
Yeah. Okay. Are you on a laptop or desktop?
I am on a laptop, but I think I'm not a part of the panelists. That's why it's just like
Oh, that's yeah. Maybe you're not in yet. Okay. Yeah, you're exactly right. You're not in yet. That's why.
yeah, join as panelist. Yeah.
Yeah. Join us, fellas. Yeah. Now it should come on. I'd like to introduce you, Yush, to a few neurosurgeons before we start.
Sure,
Saeed
yeah.
Taha is a neurosurgeon from the island of Reunion, off the
Hello.
coast of Africa, the East Coast. He's very active, and he's doing a French neurosurgery grand rounds every 2 weeks.
Oh, great to see you.
Yeah, and I'd like to introduce Takashi Khan. He's probably our biggest fan from Japan. He comes no matter what, whatever day or night, he comes.
Great.
Thank you. Nice to meet you. Nice to
And
meet you.
he's learning Spanish, and he does tumors. He's in Tokyo.
Oh,
Yeah.
great. I just visited Japan. Last week I was in Japan, and I just came back from your country. You have a beautiful, beautiful country. I love it.
Yeah, thank you. So where did you visit in Japan?
I
Tokyo?
was with Dr. Tanaka, Masato Tanaka in Okayama.
Okayama.
Okayama Rosai Hospital, spine unit.
Okayama Rose Hospital. Okay.
And Yura, are you there? She's from South America. I don't know if you're there, Yura. Oh, you don't look like you have your camera. Okay. But yeah, you've used you do a lot of Zoom, Ayush?
Yeah, I'm very familiar. Don't worry about it.
Yeah, it looks like you do a lot of promotion and advertising. No, it's not bad. It's not bad. You know, that's what we all do. Basically, we promote ourselves.
Yeah.
That's what we do.
That's the part of the new world. We have to.
Yeah. Well, why not use it? It's very useful.
Exactly.
I tell people just use it. It's an advantage you can use. If you don't use it, it's worthless.
Exactly.
I think Sarath will tell you. He seems to like it. Sarath likes it, right?
Yeah.
Yeah.
That's right. So I think today Aish will do the most of the speaking, because he's the guy who just all these fixations and minimal invasive is much much interested in minimal invasive spine.
Okay.
So as usual, Aish, what I do is I will give the introduction, and I go through a very brief presentation, and then we can go to the cases and discuss.
Sure.
Okay, very good. Yush, there's no time limit, so just go with the flow. We'll go with the flow.
Okay, sure.
Okay. Do you want to wait a few minutes, Sarath, or start? Or
Sure.
do you want to wait or start?
You're muted.
Yeah, we can start, John. Yeah.
Okay, here we
fine.
go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. This is Dr. John Bennett for Neurosurgical TV here on the beach. We have the pleasure of hosting the Sri Lanka Neurosurgery Grand Rounds, which we've done for a few months now. We've done it for a few months, right, Sarath?
Yes,
Probably
that's right.
almost a year, and
Yeah.
on mostly a bi-monthly basis. And Sarath Munasinghe is a neurosurgeon from Sri Lanka. He likes the platform. He believes in it as an educational possibility, and he's brought one of the finest laser spine neurosurgeons from India. And I'll let Sarath introduce him properly in a neurosurgical sense. Good day, Sarath.
Good day, John. Thank you very much. And we welcome you to Neurosurgery Grand Rounds of Sri Lanka. So as usual, we'll start the presentation, and So today we have the pleasure of the company of a distinguished spine surgeon from Mumbai, India, Dr. Ayush Sharma. So this is the second time he's joining with us. So we welcome Dr. Ayush Sharma.
Thank you. Thank you.
And
Sir.
so let me share my screen. Right. So I hope you can see my screen. So let's start. Right. Okay. So today the topic is controversies in degenerative lumbar spine surgery. And mainly we are talking, concentrating on the degenerative spine, the lumbar canal stenosis. So the controversy is whether to fix it or not. And if we are going to fix, when to fix. So as usual, I will just go through a very brief introduction to recap on what we are going to talk today. So if we talk about lumbar spinal stenosis, so we all know the definition. So I think this is a better definition given by the NAS. So diminished space available for the neural and the vascular elements secondary to degenerative changes. So as we all know, the diagnosis depends on the two fundamental conditions where there should be correlation between the clinical symptoms and the radiological evidence, which is very important when managing the patients. And talking about the natural cause, we know 30% of the patients might improve with the conservative measures. At the same time, 30% of the patients expected to worsen. And that category, we do have some predictive signs and symptoms. So the cross-sectional area, the presence of back pain and the radicular symptoms, whether there is spondylolisthesis or not, and also the symptom duration of more than 1 year. And this is the sequence of event and the evolution of spinal stenosis, as we all know. So just to recap these terms, disc degeneration causing the narrowing of the disc space, and then comes the settling of the motion segment, and the buckling of the ligamentum flavum, and the concept of micro instability, which can lead to anterolisthesis or retrolisthesis, and causing an abnormal motion segment, and leading into all these cascade, the bony spurs, subchondral sclerosis, hypertrophy of the facets and ligaments, and ultimately causing a static compression plus with the dynamic component, leading into spinal stenosis, which manifests as neurogenic claudication. So this is what we all know. So as neurosurgeons, we know the surgical approach may vary depending on the following factors, like location of the stenosis, how many segments affected, whether there is associated deformity, and whether there is spinal instability, which is very, very important, whether the patient has undergone previous surgery, the general condition, whether the patient is a smoker, obese patient, anemic, the state of the whether there is osteoporosis, and also surgeon's preference, his technical the competence, and also the availability of resources, at last, but not least, because however much you like, if you don't have the resources, so that's the end of the story. So what is the rationale of management of lumbar spinal stenosis? As we all know, when there is compression, generally we say we need to decompress. So this is why we need to regulate the intraspinal pressure, the blood flow, and also the metabolic status of the neural structures by decompressing the neural elements, and also by reducing the inflammatory process. And then comes the important question, whether to fuse or not. So what we have learned from the studies, the meta-analysis, the randomized control trials, so there is not much difference in the clinical outcome in patients when you compare the patients without fusion and with fusion. And also, so we know there is no significant difference when you talk about the indices like Oswestry Disability Index scores, SF36, and also the satisfaction rate of the operations of the patients. And also you need to consider the cost related with the fusion procedures, and also the side effects. But at the same time, we talk about the restoration of sagittal balance, so which is a very important concept in these days. So we know it's better achieved with fusion procedures, and also the fusion rates are higher when we do the instrumentation. So as a third world country neurosurgeon, this is one of the better guidelines that I found out when we consider all the European guidelines as well as the other guidelines. So this guideline given by the WFNS regarding the fusion surgery for lumbar spinal stenosis, and I think which is very good, and I follow the guidelines because I have the problem, I have the issue of restricted resources. So this is what they recommend. So I have highlighted two statements which is very important in my practice. So usually, I do fusion in patients with unstable spondylolisthesis with symptoms, and also the patients with lumbar spinal stenosis with loss of sagittal balance. If they're symptomatic, we do the fixation. And the first statement, patients with lumbar spinal stenosis with no signs or symptoms of instability and predominantly having the leg pain component, just decompression alone is recommended. So this is what I follow, and we'll see. We'll ask from the other neurosurgeons, and we'll ask from Ayush about his comments on this as well. So when we talk about this, the concept of instability is of utmost importance. So the definition of instability is this: abnormal response to applied stress, applied loads characterized by the movement in the motion segment beyond normal constraints. So how are we going to identify the instability? Direct and indirect signs. So this is the direct signs, translation and rotation, as well as indirect signs are there. We all know about this. So just to recap, right? So this is in a nutshell. So this is what we have been doing up to now. So anterior, oblique, lateral, extreme lateral, posterior. So we all know about this. So let's see how we are going to about how we have applied this in real life situation, in real scenarios, and in our practice. So at the same time, just last statement before we get into the cases. So we have seen as neurosurgeons unnecessary fixations nowadays, because we have seen even in I have seen in my country as well as in other countries. So most of the most of the neurosurgeons, and the spine surgeons, whoever it is, orthopedic surgeons, we know that they practice patient-centered and patient-friendly practice rather than what is called lucrative practice, which is being practiced by very few surgeons worldwide. So I think that is very, very pathetic and bad to see such practice, because when you talk about spine surgery, especially lumbar spine, we have seen unnecessary fixations sometimes. And I have seen in my country, sometimes from the same center. We don't see just discectomies and just lumbar decompressions in such situations. All the patients being even the young patients being instrumented, fixed unnecessarily without any reason. I don't know which guideline they use. So I think that is really bad. So I think the most important aspect is to consider the patient safety and the outcome. And always we need to ask the question from our conscience whether it is really necessary. And am I providing the best option for the patient under the circumstances? Because we have seen, I can give you so many examples. I can show you so many images where the young patient's life being converted into a terrible misery by doing unnecessary fixations. So that is just a brief recap about what we are going to talk today. So I would like to ask Dr. Ayush to talk about his cases. At the same time, we'll talk about these issues and the questions in between. It's up to you. It's all yours, Ayush.
Okay, so thank you, Surat, for a nice introduction, and it's always a pleasure to be here. So I always feel the best way to learn is to learn from your patients. They are the best teachers, and there's always something to learn and there are so many cases they leave an impression on you. So the idea of today's discussion is I will be presenting some of the cases where I felt there was something to take from these cases. So the topic, as you all already aware, is controversies in lumbar spine surgery. And Dr. Ayush Sharma, I'm a consultant spine surgeon in Mumbai. So let's start with the first case. She's a 40-year female. She presents to us with bilateral radiculopathy. She's on medication for roughly a month. She has some relief with the medication, and that is the time we get this MRI done, and you can see there is a big central disc at L45. So let's bring an opinion here. What do you think about this case? How do you want to proceed from here? Surat, your comments here.
How old is she, Ayush? 40, right?
40,
Yeah.
40, yeah.
Right. So it's mainly, is it back pain predominant or is just the leg pain predominant?
Only leg pain, no back
Leg
pain. X-ray I have not put it here, but the X-ray was absolutely normal. There is no there is no instability, just to say.
Right. So in my setup, I don't have minimal invasive surgery. So in my setup, I'll go for a simple microdiscectomy in this case, rather.
Okay. Any other opinion on this? So these are the opinions, options we have. We had an option of, you can give a block, maybe you can go for microdiscectomy, you can go open and tubular. So in this case, we discussed with the patient, and we sort of, in my setup, if there is no is only radiculopathy, I always prefer a block. Okay. So that is the option I gave her initially, but she wanted to wait. And so I said, fine, you don't have any neurological deficit, nothing. So in spite of my opinion, she wanted to wait. And then she comes after 3 months and she says there's absolutely nothing. And there's no pain, nothing. Curiosity, I got it. Look at the MRI. Look how much it has regressed. So the idea of this case was just to emphasize what some of us already know, and this I will quote from this NAS evidence-based clinical guideline committee, that in absence of reliable evidence in the natural history of lumbar disc herniation and radiculopathy, it is the world opinion that majority of the patient will improve independent of the treatment. Disc herniation will often shrink or regress. Many but not all papers have demonstrated an clinical improvement with decreased size of disc herniation. So basically, just to say that even if you leave these patients, they are likely to regress. Not everyone. If the patient wants this, in spite of all the surgical options we have and surgery we do, a conservative treatment does well. And this case was good enough to just demonstrate how much the body can revert back the pathology. So this was just the beginner, just to put one aspect of our treatment where we sometimes forget that just giving some patient the benefit of doubt can also work. So this was the first case. Let's go to the.
Can I make a comment, Ash?
Yeah, please.
Yeah. So now, in this type of situations, if the patient is not having a motor deficit or if the patient is not having any features of cardiac compression, so what in my practice, what we usually do, we go for what we call this conservative management initially for around 6 to 8 weeks, and we observe the patient whether there is because as we know, 80% of the patients most of the time they get better, they improve. In my setup, I rarely use blocks. I use it as diagnostic purposes. Very rarely I use it as therapeutic purposes as well. But regarding the injections, epidural injections, my experience is most of the time it's almost always it's been transient. The response is transient. So I have only seen very few cases of a complete resolution with epidural steroid injections. So what about your experience, Ayush? I think you also, initially consider the conservative treatment for at least 6 to 8 weeks and then consider surgery. Am I right?
So our protocol is to conserve the patient, but it's patient specific. If patient wants some intervention, and he has a lot of pain even in 6 weeks. We do offer blocks. So we give a lot of blocks, especially the root blocks. And we have in 2015 European Spine Journal, and you can go and see our paper. So basically, we have compared. I should have put it there, unfortunately, but you can search it. It's in my name, and we have compared say RCT between epidural, caudal, and the transfemoral block, and we felt that the root blocks are the most effective. And almost 30% of the patient who have only radiculopathy, they never come back to you, and that is our experience. So it is a good way, especially when the patients have only radiculopathy, to avoid surgery and give them time, because as you can see from this case, the disc always regress. Only problem is the pain. If you take control of pain, that is what they want. And I'm talking about pain, of course, the patient which only have radiculopathy, no deficit, no.
Yes. Right. Thank you.
So should we move ahead with the next one?
Sure. Yes, of course.
Okay. So another interesting case. She's a 31-year female. She presented with left L4 radiculopathy for 2 months, which has increased with 15 days. Okay, for the last 2 weeks. Now she's having difficulty in walking. Her bilateral straight leg raising test is positive. Left L4 is 3+. There's sensory deficit in L4, and her BMI is 38. So this is the X-ray. There's nothing much on the X-ray, but just to show you, this is the patient. She is pretty obese for 31-year-old. These are her MRI. You can see there's, of course, that L3-4, there's a disc prolapse. But this looked pretty unusual to me. For whatever reason, I felt something is not very right about this MRI. And I did a CT scan as well. And you can see there's a big osteophyte. And not only the disc, there's a big osteophyte component as well. And, she's pretty young to fuse. And that was the dilemma I had. And said, of course, we cannot ignore her, because she's already she has a significant back pain, and there's a deficit, so we need to intervene. So what do you think, Shurath? What will you offer her?
Yeah, a bit of unusual condition, is it? So yeah, I think you need to approach laterally in this patient rather than posterior or posterolateral.
Okay. So what will you do if you have to do this? How will you go about this patient?
Quite interesting. So,
because there's a bony component, and you need to tackle that, because that of course is leading to because if you see this, the foramen is getting compressed, and not only the disc. Of course, there's a disc component, but even the osteophyte is again a big culprit, and which cannot be ignored. And she's 31 years old, so you really don't want to do too much for her. Because, as we know, this fixation in young is not a very great idea.
Yeah. Right. In my armamentarium, actually, I can't think of, the best procedure for her at the moment. But, I would definitely go posterolateral and to do a pediculotomy. Yeah, so I'm not really sure about this case, Ayush. So what was your approach? I'm quite interested to know.
So exactly. So I had the same thoughts. You need to go lateral, but lateral means removing a pedicle. Then you can approach the osteophyte. It needs fusion. It needs cage. So sometimes you think out of the box. So what we did is we went from left-sided endoscopic approach, and we did it under, of course, I have all the armamentarium or the toys to play with. So I used a navigation and neuromonitoring. And this is what we did. This is the case. Sorry, I'll just mute the volume so that So this is this is what was done. Under navigation, we approached that osteophyte. So it's a transforaminal endoscopy, and you can see there is a navigation tracker. So we are tracking the osteophyte all the time. So as you track the osteophyte, you can see exactly what is happening, and this is the terraphine for osteophyte. You can sort of thin out the osteophyte. So this is under endoscopic vision. You can see this is the osteophyte, which is sort of I'm gone through the transformal approach, and this is the osteophyte which comes first, because this will always come first before I reach the disc or the canal. We know from the CT and MRI, if you're going laterally, the first thing which you will encounter is the osteophyte. So this is the osteophyte I'm trying to mobilize. It was pretty stuck, and it was a bit not easy to mobilize. Okay, so we thought the best way is to burr it out. So these are endoscopic burr, and remember all the time, it's not easy to do it blindly, because unless we thought it was very difficult. If you have a simple C-arm, the only way it was possible in this case, because as I told you, we are using a navigation here. So this burr is navigated, and then we are using the navigated burr. This is how the burr works. So you just thin out the osteophyte, and then this is as we go ahead, we are taking some soft tissue as well, and then we also the superior articular SAP. We also use another burr. There are a lot of different types of burr which you can use. They are all high-speed burrs, and then superior articular process also we thinned out. So I had enough space. So now, if you remember the trajectory, I have gone from transforaminal. I have taken the osteophyte burr first, because the osteophyte came first in my view, and then now you can see this is the cranial, this is the dorsal. I already thinned out everything, and this is the ventral. And as I go in, I expect the disc to come first, because then there's a disc prolapse, and then the dura will come. So if you go lateral, that was the advantage. And as we go ahead, this is just going through the disc, and now we'll just approaching the disc. And as you can see, this is just the small disc fragments. And if you go through the transform approach, you can, and this is somewhere here is the PLL. And as we have seen from the MRI, the disc is between the PL and the dura. This is the best part of the endoscopy. You can really go in that space, even if you don't cut the PL sometime. You can. This is the disc behind the PL. You go in. Already you have done your bony work. All you need to do is to remove the disc fragment, and this is the disc fragment which is just coming out. You can see a long big disc from just behind the PLL. So you have almost done everything without even cutting the PLL, without even removing your pedicle or whatever. And that is the advantage these techniques do. They give you a lateral window to the pathology, and you can see this is the whole disc fragment which was there, which is just sort of comes out, and the whole field is filled with disc. I'll just show you outside how this is how it looks like. So you have done everything through a very, very small window, and this is the disc fragment. Of course, we did the osteophyte, and my computer just hanged. So just I don't know why this is taking some time to go to the next slide. So this was the case. What do you think, Surat?
Yeah, it was very, very impressive, Ash, very impressive. And yeah, and considering the build of the patient, I think that was ideal for that case. So you thought out of the box, as you said. Yeah, that's a very nice case.
Yeah,
very interesting.
We felt there are a lot of difficult questions in this case, and we thought this is the best way to go about it. My computer had just the screen is not moving. I'll just stop sharing and redo it again. I think there's some. I'll just see. I'll reshare it because the slide was not moving. Let's see. Can you? I don't know why that slide had stopped moving for whatever. I think because the video it got stuck. I don't know. I will try again. Can you see the slide, Nona?
Yeah, we can see the slides. Yeah.
I cannot see it. Can you see you can see my screen, but can you see the slide of that presentation, Nona?
Yes. I can see.
Yeah. You can see the slide, but I think it's freezed, is it?
Yeah, it is freezed for I don't know because it was a video, so I don't know why it has frozen. It is simply frozen. It is need to maybe restart that PPT. So you can just discuss few things timing because it's sort of frozen because it was a video. That's why I guess. So it will take me 2 minutes to restart this. So you can maybe so that you can just do show a few cases timing. Okay, give me 5 minutes to sort it out for whatever reason.
No problem. Yeah. So let me share my screen then. So I will just go through a few cases until you get back to your presentation.
Yes, and Saeed and Takashi, just jump in if you have a question or comment, okay?
Okay.
Right. So, I mean, compared to Ayush cases, so this is just basic, for me. So this is a 60 years old female presenting with neurogenic claudication with predominant back pain rather than the leg pain. So the NMRI shows L4-5 severe canal stenosis with reduced disc space, and she had dynamic instability as well on flexion extension. So I usually, not usually, I routinely do flexion extension x-rays in my patients to look for dynamic instability. And my main issue is I don't have the opportunity because of the lack of the resources like P-lift cages. So P-lift cages, I don't have these cages very frequently as a peripheral neurosurgeon. So this is what I did in this case. So this patient, she could afford the T-lift cage. So I did L4-5 T-lift. She was more symptomatic on the left side, so the left-sided approach. And this is the result, and the outcome was very good. And considering the pain scores and ODIs, she improved very much. So I would have liked this cage a little bit more anterior, but I think it's not bad. So even with regard to the cages also, I don't have the preferred choices to choose. So there is I don't have a lot of variety to choose. So this is the flexion and extension. I think I have done a reasonable job considering the pre-op, even though there is a slight misalignment still. What do you think, Aish? Do you have any comments?
So I think it's well done. I think there was a listhesis, there was instability, and you have taken care of it pretty well. So that small maybe doesn't matter. This is definitely a case for fixation. All we need to do is make sure that that level is fused, and we maintain a good degree of lordosis. So that is exactly what you have done. I think it's job well done. So my slides are back. If you want, I can continue.
Yeah, sure. We'll continue.
Yeah. So maybe because the video it was frozen. Yeah. So can you see the slides now? I guess.
Yes.
Yes.
Yeah, we can see it.
Yeah. So just I'll do it full screen. It has gone full screen. So this is the patient. The beauty of this case, the endoscope is this is the patient on the same day walking. So that is the most beautiful thing you can do. You didn't give her a fusion. You did what you wanted to do, and she can walk comfortably on the day of the surgery. And that is the beauty of invasive approaches. So this is another interesting case. And I'll just skip few. This is again a video. If I have a video, I prefer showing them because it sort of shows you everything. So this was a patient, again a male, and see this is how he came to us. You can see how he is walking. He has a pretty abnormal gait. He's 65 years old and he's walking with a crouch. This is how he came to us, and it was very, very surprising because whatever we have seen a lot of patients, but walk like this is has a very, very different this thing. And his watch was 8 out of 9. And look at his SVA. It is sort of there's something really not right. And then of course we got an MRI X-ray done, and this is the X-ray, and this is the flexion extension view, and you can see there is a definitely an instability at L5S1, and you can see there is a bilateral facetal fusion, again confirming that there is a instability. The question is, what do you want to do with this patient? Do you want to fuse him locally, or do you want to go for global fusion? Because they're looking at the patient, he is really, really in a crouched position and with a very, very bad SVA. Any thoughts? Sure.
Yeah, I think these type of patients, you need to think about the concept of sagittal balance, and you have to think about the global, the aspect. That is my opinion, but I don't know. So, do you have the other CTs or the X-rays showing
Actually,
the?
yes. So basically, well, this was so basically all that it shows is that there is instability at L5S1. There is bilateral facetal effusion. There is no canal as such. There was no. If you see the central canal, it's almost as good as normal. So the pathology, there's no other pathology to suggest anything other way other than an instability at L5S1. But his symptoms are in proportionate to what we can see, and that was very interesting.
Do you think it was mainly due to pain?
It could be. So that is what it makes it very interesting. Okay, let me go ahead with this case. Okay,
Yeah,
because this is what. So I thought that I, at least for now, I don't want to do a full like a deformity. I thought let's do the local pathology. Let's fix the L5S1 and let's see how he does. Okay, because he needs something, but I was not sure if he needs a complete job. Sorry, it went back. So this we have already. So this is where it starts. So I planned for a minimally invasive L5S1 chairlift. So this is how you do it. You put a tube, you dock the tube to L5S1, and I always go with a complete facetal release. So this is, you can see this is the caudal, this is the cranium, this is the right lateral, this is the medial, and this is but this was a very unusual finding. Normally, because once you go, because I always go from very lateral. So the first thing I normally see is the root. But in this case, the whole thing was covered by whole 22 millimeter tube. I can only see a root. Normally, I see one root which is very, very easily retractable. But this whole field is being covered with some neural structure. So I thought my docking is a problem. So I confirmed the docking. But the dock looks very good and is very, very lateral. So lateral that you cannot go any more lateral. So I thought, let's do some more work and just release it, see what it is. Because, this is not the dura. This is just a root. Dura is medial. If you see, there's a dura here. This is a root. This is the medial dura. And this is a root. But in this particular case, there is an abnormal anatomy, something called a conjoined nerve root. So there is a conjoined nerve root. So you can see the root is being split into two parts, and that is the conjoined nerve root. Now the thing is that, okay, of course you can, now the idea is to do what we came to do. So of course we went ahead and we retracted the roots. So there's two roots. One root is going, it's like a V-shaped conjoined nerve root. So of course the root was very, very tight because there is a listhesis and there is a pseudodisc or pseudodisc, which is really causing, you can see a lot of inflammatory marks. It's like a lot of which are all around so we needed to create a working space between the two roots, because you already in a compromised space. There's a third element, an extra root. So it's a very, very cramped space. So we went ahead. First thing was, of course, we did a discectomy. You need to, and this is the disc, and this was pretty tense. So we did the discectomy and we removed the disc completely. We took out the end plates and everything. So did a complete discectomy like the way we do for any TLIF. But the problem is this space is too narrow for even the smallest of the cage. And you can see this is the dura, which is now pulsating very nicely. And this is your big root and another root. So you are literally in a very small space. This is after the end plate preparation. But we realized that even the smallest of the cage, which is a 8 mm cage, is too big here, because until unless you sacrifice the root, which of course I don't want to do, there's no way for me to put a cage, even the smallest of the cage. So we had taken a lot of bone graft from the facet. So I used the funnel and packed the space with bone graft, because there was no way I could put the cage in this case. And then this is the funnel and the bone graft was packed. But we did get a lot of bone graft, because so this is how you can see from anterior to posterior, we filled the gap with lots and lots of bone graft. The whole space was filled like the way used to do TLIF in old days. So never forget, the old principles of surgery. You never know, even in MIS TLIF, it might help you sometimes. And so this is at the end of the grafting, and then we tilted the tube just to visualize the dura. So just to show you that this is the dura and this was just the root, because the root looked so big that initially I thought I am on the dura, and then we did a MIS fixation. This is the MIS fixation, and you can see the complete facetal release, which was done in this case. Look at this. This is the beauty of the case, and this is how the patient is. All his system, everything, but just because of the pain and instability, and because this was a case of, and this is how patient is walking from that position to this position. The position was just because he wanted to have that attitude, so that it helps him to give more space for the canal. And this is what we have published, that conjoined nerve root can be a intraoperative challenge, especially if you're approaching it with a minimally invasive approach. So this is our case series on conjoined nerve root. If you're more interested to look at them, it will be worthwhile, because the almost 5% of the cases you can find a conjoined nerve root, and that is what the literature says, and it is good to understand. So I thought this was a case where there's some learning points. Any comments, Surat?
Yeah, it was really really nice, really fantastic. So your thought process was correct, and it was a very interesting and nice case. So I have seen one case before of conjoined nerve roots. So really interesting. And just one question, Ash. So do you do full facetectomy in all your? I'm sure you must be doing more minimally invasive than open TLIF. Am I right?
Yeah.
And so you do complete facetectomy instead of partial facetectomy in all these TLIF cases?
Yeah. So because I do MIS, so what happens is, and it allows me two things. First of all, it allows me a very good access. I always come from lateral to medial. The other thing, it gives me a lot of bone graft. A lot of people complain that there is not enough bone graft when you're doing MIS. I have never had a problem with bone graft, because anyway the facet is there. Anyway you are going to sacrifice that function. Why not to use it as a bone graft? So that's why we got a lot of bone graft for this case, only because so I always prefer a complete facetectomy. So much so, in some cases, we do a bilateral facetectomy if we really have to do it. I don't mind even if I have to do from both the sides, even with MIS. I don't mind it.
Yeah, no, I do the same. That's why I asked you. Right. Thank you.
I believe you have to do the complete job. It doesn't matter that you are doing minimally invasive approach. All the approach is minimally invasive, the surgery is complete. There is no way there could be shortcuts to the surgery. It doesn't matter which approach you take.
Right, great.
Thank you.
So, yeah,
Thank you
please.
very much for this interesting cases. Interesting case, especially with the endoscopic technique. So it's challenging. I know the conjoint nerve in some cases it's not easy to do it, even with microscope. So congratulations for this case. But I think it's not necessary to do arthrosis or disc replacement in this case. Now, what you do, the decompression of the nerve and I think it's enough for me.
Yeah, I agree with you. The the main culprit for sure was coming from the compression of the nerve. But in that case, there are two things. We felt there is a full facet sign, as I showed you. Other thing, even to approach it, there is already a compromised space. So we sort of felt that removing the facet was a better idea. So it gives me much more access to do what I do. Without doing that, it would have been a very, very difficult scenario. But we have done cases, even in presence of conjoined nerve root, where we have not done a fusion. And if you read the article, you will the article in the Asian Spine Journal. You can go through it, and we have even described the technique how to go about it.
Okay, thank you. It's not easy to manage flat back.
Yeah, I agree.
Yeah.
Yeah. So this is again another interesting case. It is maybe not typically degenerative, but I thought it's a very interesting case. So let's put it there, and it has a lot of questions and dilemmas about it. So this will be the last case. So this is a 56-year female. She is a case of carcinoma rectum, presented with back pain 3 months, which was increasing over 1 month. There is no history of trauma. Her VAS is 9 out of 10. She is on morphine. She has a ODI of 45. She cannot walk. She is bedridden. She is neurologically intact. And you can see there is a patch here because of the carcinoma rectum. A anterior resection of the rectum with anterior colostomy was done in January 2020. So this is the patient, and this is how she presented to us. The histopathology report from the previous said adenocarcinoma of rectum, and this is how the X-ray looks like. There's a focal kyphosis, and there's something wrong with L2 out here. And her ESR is 50, CRP is 7, WBC is 5,000, hemoglobin is bad. She is O negative again, and this is her MRI. It shows definitely there is something happened with the L2, and again these are again going with the MRI, and this is the CT scan. There is a more than almost like 40 to 50% of the body is destroyed anteriorly, and it is, if you see the angle, it is 38.8 degree, which means if collapses, you are likely to get a kyphosis of more than 40 degree out here. And we got a other blood marker. Her serum electrophoresis was normal. The PET scan, we get it done just to look out for anything. If there's any other active lesion, it says that there is only active lesion was at L1, L2. We just to rule out any other involvement, we also got a screening MRI done, and this is what we find. There's a incidental finding of intradura extramedullary space occupying lesion at D8, and this is how it is. And this is in the screening MRI, and we sort of went through literature, and literature also says that it could be metastasis sometime. And if you look at the instability scoring, her scoring is 13, which makes it pretty unstable. So with all the questions, all the problem, she is very in a bad shape, she needs some intervention. What do you think you want to do? You want to conserve her, let her be in the bed? You want to investigate further? Do you think the L2 needs to be addressed, or is the intradural pathology should be taken first? So, that's your opinion.
Yeah, I think you need a holistic approach in this patient. First of all, it's adenocarcinoma of the rectum, so you think about, you need to liaise with the oncologist and look decide on the prognosis. And then, as you correctly mentioned, you have done all. I mean, you done almost all. You checked the Saint score, and you have done the other, the primary and the other secondaries in the liver and everything. And it's a very interesting case. Rarely you see these types of metastasis as well in the intradural intramedullary locations as well. So it's a balance between the risks versus benefits. So definitely you need to have a multidisciplinary team approach and a discussion in these type of patients, and you need to discuss with the patient. And if you decide on surgery, I think you need to if I were to go for surgery, I'll consider this patient is bed bound, so you need to understand why this patient is bed bound, because it's not definitely due to carcinoma of the rectum, it's definitely due to the spinal pathology. So it has to be the intramedullary lesion rather than the metastasis to the L2 vertebrae, because I didn't see any significant compression of the spinal the thecal sac at that level, as well as if the patient is not walking due to pain, the visual analog scale was around 8, which is bit unlikely. So I think you have to go for the intradural lesion first, and then consider to fix or not. So whether to fix or not, again, as I said, you need to decide considering all the facts regarding the prognosis, the patient's condition, the wound healing, and everything.
So thank you. I think I agree with you. So what we thought is that lesion looks very abnormal to us. So we first thought, well, let's get a biopsy. Let's see what comes out of it. So we went to L2 first, just to because this is the least you can do before, just to add one more diagnosis to make us a little bit wiser. And this is what I got. There are a lot of pus from that lesion. Okay, and the moment we did that, she felt better. She could sit. Okay. And we knew that there is no neurology. So we thought that this could be why she is in the VAS 8 out of 10 is very abnormal. There has to be something which was missing. And because there was an infection, and that's why the problem. So now the culture came at Staph aureus. Okay. So she's slightly better, but she's still in pain. So and there was no malignancy in that. So we ruled out the malignancy. So sometimes we could be on for a surprise. That one of the idea to present this case is just to emphasize a simple biopsy sometimes can really make you wiser. And the blood culture also said Staph aureus. So there was we had a dual diagnosis of the pathology. Again, the question comes what to do next. But we discussed with the patient. We got our colleagues from who deal with this intradural, and they sort of felt that because there is no neurology, and we cannot tackle everything. So maybe if the pain is coming, is right now only the problem is pain. So maybe we can do something about the lumbar pathology. There is a big variety. So what the idea was to do the least. So we sort of planned it as a maybe a minimally invasive approach. So this is what we did. We went through the MIS approach. We did a fixation, and what we did is we used the transpedicular approach to put a lot of bone graft anterior to the body through the pedicle using these funnels, and we mixed this bone graft with the antibiotic, which was sensitive to the pathology, because that is where it is. And this is how it looks like. You see, there's MIS fixation, and we have even used the short pedicles for this. And this is how the whole space in the body, because you had that we use that funnels of MIS. we could fill it with. And the patient, she had the survival of this patient was almost 8 months, but we could not, see the already case of adenocarcinoma. So we could not cure her, of course, but what we allowed her is by doing a very small approach. This hardly takes around 1 hour or 1.5 hours without much blood loss. She was able to stand. She could mobilize herself with walker. She had a comfortable life. And of course, we lost her to other problem, like because of that, carcinoma. I think 8 or 9 months she was with us. But whatever time she was with us, she had a comfortable life. One of the idea of putting this case there is, just to emphasize how much even a simple biopsy can change your diagnosis and it can make you a little wiser. So these are the cases I just wanted to put.
Yeah. Very interesting. I hope the reflexes were normal in that patient, isn't
Yeah,
it? I thought
exactly.
it was exaggerated. Oh,
No,
okay,
no,
that's why I thought.
no.
Was it normal?
Yeah, and
Right.
we wanted to, of course, do the both, but these cases you have to choose and pick, and you have to
Yes.
decide. Like, there's no clear-cut answer. We could have gone wrong, but we thought that once we got that, initially the idea was to tackle the intradural. But once we got that from that pathology and looking at the pain she had, we thought this might improve her clinically. So that's why we went ahead with this.
Yes. Nice job. I think you did the best for the patient, the least you can do with the shortest time, and it was the best, I think. Right. So very interesting cases. Dr. Ayush showed us very interesting cases. So thank you very much. And let's see a second. So I will continue with a few of my cases as well. So these are just basic cases. As I mentioned earlier, I don't have much cases to show you. Again, this is just a 54 years of all female presenting with neurogenic claudication. Again, back pain predominant. So MRI again shows L4-5 spondylolisthesis. Unfortunately, I don't have all the images because these were done quite some time back, maybe two years back. I don't have the flexion extension x-rays as well, and I just have the AP. So this is again, I did L4-5 TLIF. Another one, again, same scenario. L3-4, the patient had predominant back pain. All these patients had predominant back pain, all these 3 cases. So I decided to fuse these patients. And this one, L3-4 and L4-5 stenosis, and the grade 1 spondylolisthesis at L4-5, again with the dynamic instability. So this is how the axials look like. And this is what I did. So L4-5 TLIF, but I did decompression at the L3-4 level as well because there was significant compression. And so I extended the fixation 1 level above, but unfortunately, I had to use the minimum number of screws, so I had to tackle that problem as well. And I would like to ask Ayush, in these type of situations, what would you do? So there is L4-5 spondylolisthesis, but there is compression at the level above. So I'm sure you prefer TLIF only at the level where there is instability.
Yeah. So the L3-4 also you have some compression in this case?
Yes, it had compression.
Yeah, so normally, when I do it open, I'll do the same. I'll fuse even the L3-4. If you're using the MIS, what I'll do is I'll fuse only the level which is having the instability, and I will use tubular decompression only for the level above, because the chances that you will be damaging very less bone, that you're taking out minimum amount of bone, and the soft tissue remains intact. So you can avoid a fixation at the adjacent level. So that is, if
Yes.
I'm doing open, I'll do what you did. But if
Yeah.
I'm using MIS, it gives me advantage of skipping a level.
Yeah. The advantage of minimal invasive is it has preventive. I mean, the chances of adjacent segment degeneration is much less.
Right.
Yeah. So another case, 72 years. So these were the cases where I could use these interbody cages, and all these cases I'm showing you now, I did not have the interbody cages. So I did the fixation alone. Posterolateral fixation only without the cages. So this is again L45. So just a fixation, but all these patients did very well. Another one, same again, L45. So this was done again, and can see the reduction of the listhesis is fine. And this is a severe case of neurogenic claudication with extreme difficulty in walking. He had stenosis at L3-5 as well as L3 to L5 as well as S1. So you can see there was severe stenosis at L4-5, L5-S1 as well as 3-4. So this is what we did. So without fusion, with the cages. But the outcomes were quite similar. So they all these patients had a good outcome with respect with regard to the pain scores and the ODIs, etc., etc. So what is your experience, Ayush, regarding a fixation, pedicles through fixation without any the fusion interbody cages? So have you done that? Have you done it in
Yeah. So I believe if for grade
your
1,
career, or you always did with interbody cages?
yeah, no. So for grade 1, I believe it doesn't matter much whether you put a cage or you do a fixation with a good fusion bed, because only the challenge is to create a good fusion bed. Actually, that so I prefer TLIF only because it saves me time. I do it much faster with MIS TLIF. That is the reason I choose a MIS TLIF. But I have done earlier. I have done a lot of cases where we have, for example, grade 1, the way you have done, it doesn't matter. But in cases where you have a high grade listhesis, get grade 2 and grade 3, then only putting the screw really puts a lot of stress on those screws. And then we have seen a failure. Even if you look at the literature in stable condition in grade 1, only thing by putting the cage, maybe you can get bit more lordosis. You can, that is always an advantage. But if you compare the rest of the result in terms of VAS and ODI, I don't think it matters. That is my personal opinion.
Thank you for the comment.
I want to just to point that you have much flat back. So it's the flat back, the problem of flat back. When we put the cage on 1 or 2 level, we move the contrast to the adjacent level. So in a few years after the patient came back with discopathy on the superior or inferior level of the arthrosis. So I think I do it. I do the osteosynthesis without cage in flat back, and I think it's better than the cage because we accelerate degeneration of the other level. I don't know if you understand what I mean.
Yeah. I sort of, what we do, and we sort of went through the whole cycle of this. So basically, how much lordosis you really need to give it to the patient. In spite of all the research and all we talk about and all we know, still remains a dilemma. If you see, we all do what we do, but the question, if you really, how much lordosis you should give so that you don't have a adjacent segment pathology, is still a debate. We all can agree or disagree, and I sort of understand your thought process and sort of agree to it. So what we do in MindShoot is we measure each and every patient standing X-ray scanogram, and we look at the lordosis they have preoperatively, and we sort of try to judge and try to recreate in whatever way, whether it is by putting a TILIF or a OLIF or whatever. But in spite of doing everything, I don't think we have become wiser till date, and we are still looking for answers to this
Yes,
million-dollar
yes,
question, which is sort of
yes,
still remains an enigma to spine surgeons and neurosurgeons.
yes. I agree with you. I agree with you.
Yeah. Thank you, Dr. Said. So I think that's one reason that we follow up these patients for at least 3 to 5 years because of the risk of adjacent segment degeneration. And I would like to ask Ayush, what about your experience in ALIF? Because I'm sure you must be considering ALIF especially in L5S1 because it better restores the low doses more than the TLIFs and PLIFs at that level.
Yeah, exactly. So idea of big cages is if in selected cases where we really need, especially when it comes to degen, scolion, and things like that, it allows you two things. First of all, it allows you to have a very good base, a solid fusion base, because of the size of the cage you can put in, and then you really get a extra lordosis out of those big cages. So I do OLIFs, but because it allows you to do multiple level, you can do from L2 to S1 in a lateral position single setting, and that is what I do. So, but I always treat patients uh, according to what they need, and these are mainly for cases where there is a severe mismatch in their parameters, and you really want to do a lot because having said everything and having done quite a bit of them, I sort of, my principle is to always do the least. Whatever you can get away with the least, that is always best for the patients.
Thank you. So another case, 54 years old female with 345 L45 stenosis, and also she had L1 and 2 and L2 3 lateral recess stenosis as she was symptomatic. So again, you can see L45 spondylolisthesis is the grade 1 with instability, and again the same thing. So from L3 to L5 did the pedicle screws, and the patient did very well post-operatively. Another one, same scenario. Sorry about that. So another one, 64 years old female, again, quite a similar situation. Back pain predominant, 3, 4, 4, 5, L4, 5S1 severe stenosis. So again, did the same thing. This is from L3 level to S1. And I had to use 2 screws on the right and 3 on the left because she could only afford 5 screws. So I always have this problem with regard to the number of screws, as well as whether the patient could afford a cage or not. So in this type of situation, what is your opinion, Ayush? I mean, in this case, what would you have done?
So if you are doing, that is where that is why I sort of shifted to minimally invasive, because if I have to do it open, if you're doing so many levels, you need to put screws. There's no doubt about it. Okay, but even up to 3 level at least, I can. It takes bit more time, and it's sometimes you get tired. but the tubes can be used and you can decompress all the three levels without, and you spare the whole lamina and everything. So you don't need to put the screws. So that is where, from doing what you did or what you are doing, the central, we used to do the same central laminectomy and do a posterolateral fusion or something like that. Now we have shifted to doing only the tubular decompression, even when it comes to multi-level, and that is where we are today.
Thank you. So, right. Yeah, I mean, similar type of cases again. Little bit of grade 1 spondylolisthesis, severe compression. Same thing I did with good outcomes. This is after 3 months. She was doing very well, and this is just an interesting case where I did the T-lift at L45, and this is the cage has migrated after some time. But the patient was, symptomatically better, improved a lot, and she did not have any new features of thecal sac compression. But you can see on flexion extension waves, there was posterior migration of the cage. So I would like to ask you, Ayush, this type of situation, what would you do?
So it totally depends upon patient symptom. If I have a case, and maybe I should have put it, I have a now 6-year follow-up. The cage looks completely in the canal. It is your case is pretty good compared to that. It is migrated completely posteriorly, and I have been asking this patient to undergo a revision for last 6 years. He refuses every time and is absolutely symptom free. So, now I'm convinced that maybe he doesn't need surgery. But if you see that X-ray, and maybe someday I will show you, you cannot believe your eyes how the bad X-ray looks like. But, so it's not easy to revise them. And the only reason you should revise them or think anyway, if the patient is symptomatic, or you feel that it is likely to, cause a impending neural damage. Otherwise, normally, if it will settle down once it fuses, it doesn't matter where it are. But of course, you need to keep a watch on these patients. That is for sure.
Yeah, completely agree with you. I did the same. And patient refuses, but up to now, she is asymptomatic. So we'll keep an eye on the patient. This is another bit interesting case. 60 years old female. She had grade 2 spondylolisthesis, and she had undergone unilateral fixation only 1 year back, and but she had a considerable amount of improvement of her symptoms with that, and she came to me following a fall and with recurrent symptoms and the predominant leg pain component she had. This is her initial X-ray after the first surgery, and you can see a considerable amount of spondylolisthesis. So I actually wanted to do a fusion procedure for this one, but doing a fusion in this type of patients is not that easy. It's very difficult due to the adherence of the scars and the adhesions, as well as it's very difficult to identify the correct anatomy. So as expected, it was really difficult. So so I could not put any cages on this patient. So I just did I extended the pedicles through fixations. So this is what I achieved. You can see the spondylolisthesis is considerably reduced. So the patient had a significant improvement in her symptoms. Yeah, so would like to ask, would your opinion, value your opinion in this case, Ayush?
So as I was talking earlier, if you have grade 1 listhesis, if you put screws, it doesn't matter. But where the cases like this, where you have high grade with a lot of stress, if you put only screws, it is bound to fail. Okay, so that is one thing. So at the beginning, it should have been a interbody fusion to prevent this sort of a situation. That is one thing. The other thing, if like it comes to you, what if this patient comes to me, what will I do? That is another question. So what again, why the, as I showed you, we what I do is, again, because of normally the good part is, most if someone has done a open laminectomy from posterior, he leaves those facets from me to go from lateral. Okay, so that is where I always get a MRI, and most of the time, if someone has done an open laminectomy, they always leave the lateral window for me. So I approach. So I again, it's very risky to go to the scar and everything. So what I do, I go lateral to the scar, take out the complete facet from lateral. Okay, it's very difficult to do open because you need to really struggle, retract, and everything. But tubes allows you to literally dock on lateral. So again, we take out the facet from lateral to medial, and even without touching much of the previous scar, we can sort of most likely we will be able to put a cage. So that is where what I will do.
Right. Thank you very much. And I think that's it regarding my cases. If any of you have questions, so you can ask from Ayush. So what about the like I mean, what is your preference? As you said, you are preferring more endoscopic approaches than open. So like how many open cases you do nowadays, if you consider, say, per month?
In last 2 years, one open case.
Just one open case.
One
Right.
open case in last 2 years. So
Right.
that, but we've gone through the cycle. I was completely open surgeon 10 years back. And as I have gone ahead, and we converted few of the cases to tubes, and then, but as of today, for whatever reason, I find it much easy, and even the cases. So if some of the cases I showed you, it would have been almost impossible, or at least very, very difficult to do it through a conventional approach. But as I told you, a endoscopy or a tubes allows you to approach through some different approaches, which was not possible through conventional posterior. And that is where I see the beauty of MIS. Just not that you spare muscle or you do a small incision surgery. It also allows you to approach the patient slightly differently sometimes. And in few selected cases, like the case I showed you, it has this definitely advantage. And that is where I am a big proponent of MIS.
Hello, sir.
What
I am
about-
Dr. Priyank. Hello, sir. I am Dr. Priyank
Welcome.
from Patna. Sir, are you saying so? It's always happen in these cases of listhesis. You will be going to recreate the lumbar lordosis as like that of natural by minimally invasive surgery only, or I think so it would be more, we can more create natural by thorough opening the spine.
So thank you, Priyanka. So I can tell you I have done it through open, and now I do through MIS, and I can do it more through MIS. That is my answer. If you no matter what cage you put through open, if I really need to create big lordosis, I'll do a olive cages, and these cages can give you much more lordosis than it, no matter how much you do with a T-lift. So the MIS is not, doesn't restrict you from creating those lordosis. In fact, we can do much more than you can do through open, because if you use the big cages, even the cage comes with an inbuilt lordosis of sometimes 12 degree, and that is not important. The importance is because of the size of the cage, you can really get the height back. But because your T-lift cage are so small, they simply go in and they simply sit, but they don't give you the advantage of restoring the lumbar lordosis. And if it, of course, open surgery allows you to do much more of a facetal release, but I can tell you, I am much better when even in comes to posterior release with MIS and through than to open. So MIS is not a limitation when it comes to getting the lordosis back. That is, at least that is what I believe in.
Sir, so that is the only benefit we can advise the patient to return to work earlier in MIS rather than the open. That is the only advantage, no, sir?
No, this is one of the advantages. There are a lot of advantages.
Okay, sir.
Return to work is definitely early. Other thing is the risk becomes less. If you read our paper, we looked at the incidence of dural tear in open versus MIS, and the incidence of dural tear was significantly less in MIS surgery. Then even our paper, we didn't see any reduction in infection rate, but their paper we suggest that the infection rates can also be less because you're using a small incision. And the last and not the least, long-term follow-up, if you look at the ASD, the chances of ASD, adjacent segment disease and pathology, are likely to be much less, as Shurath was talking about, because you are doing much less muscle damage. So, MIS is a complete package. It gives you a lot of advantages. That at least that is what I believe in. That has been my thought process.
Okay, sir. Thank you, sir.
Thank you, Priyanka.
Dr. Deepak, where are you from?
Sir, I am from Patna.
India. He's from India.
Okay, welcome.
One question to Ayush. How much is a tail-lift cage cost Indian rupees?
So it depends which company you are using. If you're using a local company, Indian made, it costs around 5,000 rupees, okay, to 7,000 rupees, okay. That is what it is for a local made tail-lift cage. And if you're using maybe Synthesis Medtronics, between 25 to 30,000 rupees.
All right. Yeah, but in Sri Lanka, it usually costs around 100,000 rupees, 100,000 Sri Lankan rupees. So approximately around 30,000, 35,000 Indian rupees. So it's quite high, quite expensive.
So the most expensive cages which I use, and with their expandable cages from Medtronics, will cost me 35,000 rupees. The regular cages, which if patient not affording, we can use is which are made, of course, locally manufactured and made in India. They are as cheap as 5,000 rupees and even can be as cheap as 3,000 rupees.
Yeah, I'm not talking about, these Medtronic and all. I'm just talking about the Chinese or the Indian cages. So it's really expensive. So that's one of the big limitations. Unless the government provides us through the, that system, it's really difficult for the patients to afford that much. That's one of the limitations. And just one last question. So what about, nowadays, what about these unnecessary fixations in your country? Do you see it regularly? So what is your opinion on this unnecessary fixation? Because, we all know that, everywhere you see these unnecessary fixations. What is your thoughts?
So that's what there is always these things happen, Sometimes it because, the surgeon believes in, so maybe that belief is not right, or sometimes we do it just because it helps us in some different way, okay. So that is where it is. But the fixation has its own caveats, and we all know that if especially when you are dealing with young, you should be careful, okay. If you're doing fixing a 60-year-old or 50 years old, even if you do a bad job, it's okay. But especially what I believe is you should be very, very careful, because you fix it, and if you have not created a good balance, he will require a lot of revision, a lot of surgery, and you will make his life a little bit worse. So at least consider not fusing patients who are active, who are young, and that at least that is what my opinion will be.
Yeah. So I think that in spine surgery, the decision making is the most important thing. However skilled, however talented you are, I think the decision making as well as the attitudes towards the patient is very, very important. Otherwise, however much you are skilled or you are a brilliant or excellent surgeon, if your attitudes are poor, then there's a question with the value of your talents and skills, isn't it?
Yeah, I agree. Completely agree with you. I completely agree with you. It's the most, I think, in spine, the $1 million question remains the decision making, and we all try to do our best. That is what we thrive to do.
Yeah. So
thank you very much, Dr. Sharma. It's a great presentation. I hope to visit you, your institution, to learn endoscopic surgery.
You're most welcome. Anytime, let us know. You're most
So
welcome.
why don't you share your website?
Yeah, sure. I'll
just show us around. Show us around your laserspine.in, correct?
Yeah. Laserspine.in.
Okay.
So you can go through it, and if you interested, you can even write to us. If you want to see endoscopy MIS, we will be more than happy to host. We have a fellowship program in our unit, and which allows visiting surgeon up to 3 weeks to 6 weeks. They can come, and you can.
Okay, that's news. That's very good news for the community.
Thank you, Dr. Santoristan.
Yeah, let's see the info there. So it's on online forever, YouTube forever. Everything forever except for YouTube.
Thank you, Surat.
Thank you, Said, for joining us. You have been a regular surgeon who is joining us. So thank you very much. Appreciate it. And thanks a lot, Ayush. So excellent presentation with a very interesting and rare cases we saw today. And so we hope to connect you for the future presentations as well, so you can talk on an interesting topic. So let me know, so we'll organize that in the future. And again, thank you very much, and highly appreciated your dedication and your presentation on this event. Thank you.
Thank you so much. Thank you.
Let me just briefly show you around the website. You can probably give us a little guide there.
Yeah, so if you go to this website, you have everything. You have spine surgery. If you go, there are a lot of just click on that. There is a YouTube link, and if you look at those links, you have
a YouTube channel, right?
Yeah. More than 70.
Let's go there right now.
Yeah. You can
laser spine. You have quite a good.
And you can
1,400 followers. That's not bad.
Yeah. So you can look at some of the lectures I just gave. You can look at the videos, some of the cases. So some interesting cases. So it gives you most of them on MIS and techniques and everything, and you can just follow it. And you can if you want to contact us, our contact details are there. We also run a fellowship program, and we allow people to visit our unit, and we are more than happy to have anyone who is interested to learn few spine things. And we will also take you around Mumbai if you come to our unit.
Okay, very good. Okay, thank you, Surat, for arranging everything, and thanks, Saeed, and thank Ayush, and we'll see you in 2 weeks.
Thank you so much. Bye.
Thank you, John. Thank you.
Bye.